Okay, so thanks to Nancy and David for having me, and thanks to Elvin and Ralph for organizing the symposium. I'm gonna just pull up the slides here, and I'm gonna be presenting this. I'm Vivek Jain. I'm an assistant professor in the HIV/AIDS division at San Francisco General Hospital, and I'm presenting this talk really on behalf of Dr. Gabriel Shami, who's our colleague at San Francisco General, and he sends his regrets. He couldn't be here for the symposium. He's in eastern Uganda right now working on implementing community health campaigns as we speak this week. So I will do my best to convey his research. So as everyone in the audience is aware, there are several large-scale clinical trials going on right now, launched and started, that are evaluating the strategy of universal HIV testing followed by universal provision of ART, the so-called test and treat strategy. And these are all studying implementation of different testing strategies as the front end to a test and treat program at a population level. And in the talk today, I'm going to try to give a comparative review of community-based HIV counseling and testing strategies that have been implemented and worked on. And then I'll spend the second half talking about one strategy in particular that our group has done a lot of work on, which is the community health campaign or community health fair approach. And this approach is a central part of the SEARCH study design, which is shown here. And this is a large cluster randomized trial of universal ART versus standard ART that our group has just launched this summer. So in the vein of implementation science, the implementation gap in HIV testing is actually very straightforward, because knowing your HIV status is a first step into entering the HIV care cascade. Without that, we can't even begin. And with the wide availability of point-of-care HIV tests, immediate results, and widespread availability of those even in resource-limited settings, testing theoretically should be doable. But despite this, especially in sub-Saharan Africa, testing is very inadequate. So in one survey, I'll just go through a couple of salient points. In one survey of 29 sub-Saharan African countries, only 15% of adults had tested in the past year. And as you can see on the left, a couple of other points. Among Ugandan adults, one study has shown that over half of men and over 30% of women have never tested for HIV. Less than a quarter of HIV-positive Ugandan adults are aware of their HIV status, and the median CD4 count at the time of diagnosis in clinics and facilities is unfortunately very low, under 350. And on the right, we look at what are the barriers. Why is there such a testing gap in terms of access of a test that we've got in our hands? And there are many barriers. Lack of awareness of HIV risk, the fact that early HIV disease, the time frame when we want to be testing people and diagnosing them, is asymptomatic and people may be feeling healthy. The fact that facility-based testing, which is where most of the testing is happening, is centralized, and that presents travel barriers, and it also presents long wait times and costs for patients to get to these facilities and then sit through a day waiting for the test. Stigma is an enormous issue. With a lot of heterogeneity in it, but is a huge issue throughout the world. And the simple fact that provider-initiated VCT depends on you having already engaged in care. It doesn't get to the people who are currently not engaged in care. So for this presentation, I'm going to just give a quick overview of community-based HCT approaches that have been looked at, and then go through some outcome measures so we have sort of the lingo of how these are looked at. And I want to really refer you to this excellent review by Amitabh Suthar et al. This is a great paper that you can gives an excellent overview of all these testing approaches. We were in touch with them as they wrote this paper, and some of Gabriel's data is included in this review. Now just to switch over to outcome measures. So when we say, how quote unquote good is an HCT approach, well, it really depends on what outcomes are we looking at. And there are a lot of different outcomes that one could look at. So let's just take uptake, which is defined as the number of people who accepted testing divided by the number who were offered it. Coverage, we're going to focus on that word a little bit more. That's the actual number tested divided by the true denominator. Who is the entire population in the denominator of the target population. The proportion of first-time testers as a measure of, are we reaching people who've never tested before? What is the HIV prevalence among those tested? They're the most basic, very important. What's the proportion of the HIV positive individuals for whom this represents a first-time diagnosis? That's crucial. What is the CD4 count distribution bell curve like among the people who are testing positive? The hope is that testing strategies will shift that bell curve to higher CD4 counts, which will mean that we're capturing folks at earlier stages of disease. And then we get into even more implementation of what are the features of their entry into the HIV care cascade? Who gets CD4 staging right away or soon thereafter? Who gets successfully linked into a facility? And then, importantly, the cost. What does it cost per person? So now I just want to focus in on these community-based approaches versus facility-based approaches. And as you can see, mobile testing, shown in this green box, along with index and self-testing, so index being you test somebody and then test their immediate contacts, as well as self-testing, provide a kit and instructions and let somebody self-test and report the results. Those have achieved in these studies the highest percentage of HCT uptake. And then in the red box, you can see a real drop-off in venue-based testing or facility-based testing. And this is at workplaces and schools, and these are for the reasons I mentioned before. There's logistic, money, and time barriers to getting that testing done in facilities. And this is a slide with a lot of data, but really just shows a couple of points. So when we look at how well different approaches are reaching target population, the outcome called uptake, which I showed on the earlier slide, that really doesn't provide an adequate measure because the denominator when we talk about uptake is those who were offered testing. Really the metric we want to look at is coverage. What proportion of the entire catchment area, the entire target population, actually participated in your testing approach? And in this arena, the mobile and door-to-door approaches really lead the way. These are shown in green. These are a bunch of studies that have utilized variations on mobile and home visiting testing. Whereas facility-based approaches are here in red, and those achieve significantly lower coverage in comparison. And really wrapped up in this is the inherent challenge of knowing and measuring what is the true denominator of people you're trying to reach with the testing approach. And for the purposes of our research, which I'm going to detail in just a second, we relied on some Ugandan census projections initially, and then in a subsequent study actually performed a quick census of a region. And this was, again, to get at the real denominator to give us this coverage number. And then the last point on this slide I want to make is highlighted in blue. And that is that not only do mobile campaigns provide better coverage, sometimes mobile campaigns can be done in very short durations of time. And I just highlighted the study by Lugada there, as well as Gabe Shamy's study, which you can see in the duration in months. These were large-scale testing campaigns performed in a fraction of a month, as opposed to some of these others that took many months. So now, when we get to different outcome metrics, I mentioned that CD4 count distribution is important, and I just want to really highlight CD4 count distribution among first-time testers. So these are people we don't think are in care, they're not on therapy, and these are truly their first diagnoses. So what's the first-time tester prevalence? In this review by Sutar et al., it was 62%. According to this pooled estimate across all studies. That's pretty high and very encouraging. We know there's some misclassification among participants when you ask them, is this your first diagnosis? What's the proportion of people with a CD4 count above 350? And I guess we'll call 350, good or high, although we know that 350 is clinically a CD4 count where you're having clinical problems. But what's the percent with the CD4 above 350? 57%. Also encouraging and could be better. And then when we get to what's the entry into the care cascade, how many had staging performed right after diagnosis? 80%, so also encouraging. So a summary of these comparative approaches, just the takeaway message are that the community-based approaches offer many advantages over facility-based approaches. Mobile and door-to-door testing get the highest rates of coverage. But really importantly, I don't think any single approach is going to be an answer to the front end of a test and treat strategy, and combination approaches are likely going to be needed. So now let me shift from the background and just talk a little bit about the work led by Gabe Shamy in our group over the past few years. And what he's really done is to pilot the concept of doing rapid, efficient health campaigns taking place over the course of only 1 or 2 weeks that aim to deliver services that address multiple diseases, not just purely HIV testing, and also offer preventative and treatment services in the same provision. And this campaign has several features, and the goals are for it to be decentralized. It's not at facility. For it to offer reduced travel costs because of that very fact, for it to be a multi-disease platform, testing for diabetes, hypertension, malaria, and TB, as well as HIV. And wrapped up in that concept is to normalize HIV testing as just part of routine healthcare and not its own specialized thing, and you're here just for an HIV test. So it's really to put HIV in the middle. And then related to all this, to screen asymptomatic persons as part of normal health. That's how we're going to find people at earlier stage disease. So here's an overview of the various services that we offered at the first community health campaign in May 2011. And this was a 5-day campaign that offered testing for HIV, malaria, TB, diabetes, and hypertension. And then the prevention services are shown in the lower left. Treatments were given both for any diagnosed malaria, and then deworming therapy was also given to children. Linkage to care was offered for these diseases that we sought, and there was a provision of immediate ART for emergency situations where CD4 count was less than 100. The campaign was in southwestern Uganda in the Mbarara district in a geographic parish called Kachurere. This has a target population of about 6,300 persons, according to the Ugandan Bureau of Statistics. And importantly, this was a community that was not going to be part of the larger search study which our group is involved in. It's a cluster randomized trial. A closer map here of just the parish, and this is only to illustrate that the campaign had 3 sites, 2 days at one, 2 days at another, and 1 day at one. And we spread these sites throughout the parish to minimize distance for participants. So the goal was that every participant would live relatively near one of these 3 sites. Some photos of the 3 campaign sites. As you can see, very rural areas, and in the second photo, the site of a primary school grounds that was converted. And you can see the white tent there in the middle. That's a wedding tent, and those were the tents that we pitched the fair under. To mobilize the community was incredibly important to get people to come and participate in the campaign. And the local elected political leaders, the LCs, they designed and executed the community mobilization plan. And this consisted of church and mosque announcements, posters and pamphlets that were distributed. You can see a poster here pasted on the side of a house. And just one small detail, you can see that HIV is listed not first, but just as one of the many diseases for which services would be offered. And then a lot of radio announcements were made as well. At the campaign, we had a small field laboratory run by a group of excellent technicians. We only did finger prick-based testing, so no phlebotomy due to time considerations and biohazard safety considerations. We did rapid HIV antibody tests, point-of-care CD4, the PIMA. We developed a way to take a finger prick sample and measure that for viral load, not point-of-care on site, but in a local lab. We did malaria rapid tests, and then also blood glucose from finger stick, and blood pressure, of course. Some photos from the campaign and our participants. There was a lot of participation in the community. And you can see here the basic results in the first campaign. Really robust participation. 4,343 people were screened over only 5 days. And this represented 74% participation or coverage from the underlying community. The average transit time from the front to the end of the campaign was 1.5 hours, so pretty streamlined. And what we found, an adult HIV prevalence of 7.8%. 35% of adults reported never having tested for HIV before. And of the people who tested HIV positive, 46% were felt to be newly diagnosed. Now, this is the CD4 count distribution of the people newly diagnosed. And this is an important slide because you can see that 64% of those newly diagnosed with HIV had a CD4 count above 350. And this was the hoped for result, that by taking testing out into the community, out to the periphery, can interact with patients in a way that gets them diagnosed at much earlier stages of disease. In terms of non-HIV outcomes, we also, as I mentioned, looked at other things and found a high prevalence of hypertension, 28%, diabetes at 3.5%, and we did a lot of service delivery in this only 5-day campaign. Over 700 doses of mebendazole and vitamin A were distributed, treatments for malaria, and over 2,000 insecticide-treated bed nets were distributed. So 1 year later, in 2012, we then went back to the same community and did a repeat health campaign. Now, and the main motivation here now were twofold. What first was to assess the uptake of a health campaign in a second year, where it's being repeated in the same area. This is really important when we think about test and treat, is what will the acceptability of annual repeated testing campaigns, will people participate? That's a crucial underpinning of test and treat. And the second motivation was to understand characteristics of people who would attend versus who will not attend a health campaign. And I think there needs to be focus on those who do not avail themselves of a service that's being hosted in their area. So to do that, we performed a census on the district, and that was really so that when people came to the campaign, we'd of course know who the people who showed were. We would also know who didn't come, who was in the census but didn't come to the campaign, and then what comparison can we make between them. And the results of the second campaign are shown here. Again, vigorous participation, just under 4,900 people screened over 5 days, and around 65% adult participation, HIV prevalence around 10%, and again, median CD4 among people newly diagnosed, 436 cells. So again, quite a bit higher than what you would see in a typical facility-based testing approach. Now, one thing we saw in the first community health campaign in 2011 was a gap in male and female participation. So you can see this in the lower left figure, which is an age and gender histogram, and you can see that in the age 20 to 40 bracket, there was a decrement in male participation. And this is a well-known feature of service delivery. Males in that age category have less participation in healthcare activities. So in the implementation science of campaigns like this, we wanted to see what we could do about this, and the local leaders and participants in the campaign came up with a community-derived intervention that they felt would be compelling, and that they felt would improve participation by men. And this was a T-shirt incentive imprinted with the logo that health is made at home and only repaired at a health facility. So this was offered to men who then participated in the 2012 campaign. And what you can see in the figure in the lower right is the same age and gender histogram, and you can see an improvement in the male participation in the age brackets that were problematic. So, and in this second campaign, when we did adjusted multivariate analyses looking at comparing the people who participated compared to the people who didn't, and looked at predictors of not showing up to the campaign, gender was actually not a significant predictor, so that was encouraging. So with my last two slides, I just wanted to close by highlighting the fact that if we find ways to improve performance on an implementation problem like achieving a high rate of HIV testing in a community campaign, this is really tantamount to solving a sizable fraction of the whole cascade of care problem. And shown here on the left is how we normally conceptualize the cascade of care. And in a community health campaign like what I've described, this is our vision of what we're doing. We're collapsing several steps of the cascade of care into one service delivery point in the local area where people live, and combining all of that into one encounter. And over time, we think this cascade can be compressed even further, for example, by providing the first prescription of ART at the campaign for someone who's newly diagnosed and is not on therapy. And that's something we're going to be looking at. So just to wrap up in summary, we feel that community-wide health campaigns can be a successful strategy for rapid scale-up of HCT. Linkage after testing is essential, and that's a point that cannot be overemphasized, and requires effort and buy-in from local clinics who are going to receive these patients who are diagnosed at community campaigns. And the other point to really drive home is that we think no single approach is going to be the key to achieving universal testing, but rather that combination approaches will be needed. And in the SEARCH study, our large cluster randomized trial, we're combining community health campaigns followed by door-to-door testing for people who don't participate in the campaign, and that's the combination approach. And since opening our study this past June, we've enrolled over 100,000 individuals in Uganda and Kenya in certain communities, and we're looking forward to future meetings where we can share the results of how this approach, this engine inside Test and Treat, how that's working at a larger level.
Great, thanks so much.
So thanks to everybody.